The topic I've chosen to share with you is the challenges around what is our compliance system in long-term care. And the inspection and monitoring systems are most effective when they're backed up by tangible consequences for non-compliance. And I'm going to talk about some of the issues that we have in BC, and arguably this exists in all jurisdictions in Canada. So just to give everybody a little bit of a viewscape, just to remind us all, most of you already know this, we have a total of 346 licensed long-term care facilities in British Columbia. Most of them, 297 of them, are facilities with publicly subsidized beds. Some of those have a few private beds as well, but most facilities have publicly funded beds, and most of them, the majority of the beds, are publicly funded. There are 49 facilities with only private pay beds in BC. All of them are licensed. They total up to just over 32,000 beds. And you can see that most of the beds, again, are publicly subsidized. And you can see that breakdown. We generally talk about a third, more or less. A third of them are operated by health authority, a third are contracted for-profit facilities, and a third are contracted not-for-profit facilities. There's 4,300 private beds in BC, about 1,500 of them, so a little less than half, are co-located in a facility that also provides subsidized beds, and just over half of them are in facilities that only provide private pay beds. So what is the regulatory framework, the legislation? And here in BC, we have two legislative frameworks that govern our licensed long-term care facilities. One is the Community Care Assisted Living Act, and the other is the Hospital Act. And so Community Care and Assisted Living Act, most of you are familiar with. The majority of our facilities are covered by that. Certainly anything built in the last 20 years is going to be covered by CALA. It also covers assisted living with a different set of regulations. And it has attended to it the long-term care regulations. The Hospital Act sites are about just under a third of our sites. They tend to be older. They're not exclusively in the health authority. They tend to be weighted a little bit more to health authority owned and operated sites, but we certainly see Hospital Act sites in the not-for-profit sector and in the for-profit sector. And then 3% of facilities have some of their site governed by CALA and some governed by Hospital Act. And these are generally older facilities that have built new additions or wings that have come under CALA, and the old site or older units come under the Hospital Act. They have different rules, standards, and oversight mechanisms. From the public at large perspective, people don't feel or experience a material difference if they're in a long-term care site under CALA or under the Hospital Act. They're more subtle differences, but part of the challenge is that when we look at what are the actual legal duties and obligations, they are different, and our practice may be that they're more homogenized than they might otherwise be. But that's by the default of practice versus what is actually in the legislative framework. So all licensed facilities either follow residential care or Hospital Act regulations. So, the act is very broad. To change an act requires the legislative authority to actually vary an act. Most acts have regulations attached to them, and regulations are easier to vary. They can be varied by ministerial order. They do not require the consent of the legislature in order to vary the regulations. And so, it's interesting reflecting on Andre's comments and others that have talked about our focus on a clinical view of long-term care when we look at what are the things that we regulate when we're talking about our quality in long-term care. And Carol talked about this as well. What is the measure of quality of care from the resident's perspective? Because what we're looking at is how are the medications managed? The nutrition, what we're looking at is the balance in terms of the Canada Food Guide. We're looking at the diets that are offered sufficient to meet the different needs. So, are you able to offer a pureed diet, etc.? Not really talking about does the resident like the food, or are we seeing weight gain, weight loss in the residents, interestingly enough. Health and hygiene, again, looking at a lot of our infection control processes. And certainly we saw during COVID that when we looked at controlling this environment, I think there is an argument to be made we lost the plot a bit around the purpose of long-term care. People who live in long-term care don't go there to be cured or fixed. That's what you do in acute care. People go to long-term care to live out what is ostensibly the last couple of years of their life. And so we applied to that setting the same degree of rigor around infection control that we apply to an acute care setting. And I think upon reflection, many of us will realize there were definitely some unintended consequences. Certainly when we talk about the visit restrictions, other things we did, like some care homes would, there was a big emphasis on decluttering, which is another word for taking away the personal possessions of a resident in their room. And for what purpose, right? At the end, we did it under the guise of infection control, but I think, this is that person's home. And so how do we manage that and manage that risk? Regulations look at the facility requirements, but that generally is not around, it's the square footage per person, et cetera. And there's lots of variations to deal with our older and aging facilities. But again, it isn't linking to those things in a facility that the person living there is going to value. So what are those kinds of things that are going to create that home-like environment for somebody? Sometimes, in fact, our regulations are contrary to that in terms of what we require. Staffing and management, we certainly look at things like ensuring people have had criminal record checks. We use generalized language about staffing sufficient to meet the needs of the resident. We don't specify what that looks like, and I think that's gotten us into a place where we've discovered that maybe we need some more specificity there. Record keeping, obviously making sure people have the documentation they need on hand, and that they have the appropriate recreation programming to support the residents. But again, we look at that, interestingly enough, from the perspective of a program for the residents writ large. What we're not recognizing in our regulations is that when we defaulted to complex care as the licensed site, we created an environment where people are on a huge spectrum of different abilities physically and cognitively. You have people in long-term care who have very light care needs, who have high physical function and moderate cognitive function. You have people in long-term care who have very limited physical function to the extent of being a total care person. Some of those people actually still maintain fairly robust cognitive function, some don't. And so how do we meet the needs of this broad, diverse group of people? The regulations don't get to the heart of that. They simply say there needs to be this type of programming available, and not looking at the engagement and the diversity of the residents that live there. So the licensing regime, we have a director of licensing or an inspector of hospitals. And the inspector of hospitals really is a throwback to another era. And in most practical terms, at the health authority level, it is the licensing officer that assumes that role. So there's a provincial director of licensing appointed by the ministry as the steward of the community, of the health authority community care assisted living, and they oversee and ensure the safe care of the persons in licensed facilities. But that is delegated down to the health authorities through the medical health officers, who are the body where you find our licensing officers who do the facility inspections. And it's the medical health officers who issue the license, suspend the license, or cancel the license. Under the medical health officer, through their agents, the licensing officer, there are routine inspections, there are investigation of complaints. Some of those are done by licensors. Some might actually be done by the medical health officer, him or herself. Licensing officers are monitoring for compliance, and it's the medical health officer who will recommend to the Board of the Health Authority for the appointment of an administrator if that is what is required. So enforcement. It's progressive enforcement or light touch enforcement, and there's different views on this and different terms used to describe it, but essentially you start out with education and support. So when you see we want our facilities to be successful, so we provide the education and the support for them to be able to meet their regulatory requirements. We may find it necessary to increase the monitoring for a particular site, so we're going back more frequently. We may find it necessary to give verbal or written warnings depending on the severity of the deficiency and the repetitiveness of the deficiency. We can attach terms or conditions to their license. We can appoint an administrator. And then the ultimate is we can suspend or cancel the license. Now, the challenge is that on paper, it would appear as though we have a robust system of regulations, we have a robust system of monitoring, and we have a system of enforcement. And that enforcement, the most severe outcome is the suspension or cancellation of the license. So in theory, operators have a very compelling reason to comply with the standards of the regulations and to meet their obligations. But the reality is something very different. And the reality is that the use of suspension or cancellation of license is very, very rarely used, in large part because if a medical health officer in a health authority cancels or suspends a license, what are we going to do with the people living at that site? There's almost this tension or conflict between my duty and obligation to monitor this site, mine meaning the health authority, but I'm going to have to deal with the consequences of non-compliance. So I have an incentive to make, in theory, I have incentive to make the site compliant, but there is an argument to be made that also gives me an incentive to give a site many, many chances, perhaps too many chances, to become compliant with the legislation. So again, the most extreme consequences or severe consequences for non-compliance with regulation in our system, as I've said, under CCALA and under the Hospital Act, they're almost identical, with the little bit different, where we can vary the original terms or conditions of the license under CCALA, which is not really a remedy available to us under the Hospital Act, and under the Hospital Act, withholding amounts payable, which is not something we do under CCALA. So to give you some idea of how seldom this is used, so this is the period of 2002-3 to 2019-10. So this is what a 7-year period of time, and this is taken from the Ombudsperson's Best of Care report in 2012. And interestingly enough, we don't track this data on an ongoing basis. So you can see that over this 7-year period of time, there were only 35 occasions under which conditions were attached to a license. Now, usually the condition that we will attach is that we will suspend new admissions for a period of time. And you can see that we never did it in Northern Health. It was basically Interior Health and Fraser Health where you saw the bulk of those. But that's over a 7-year period of time. We didn't vary the conditions on any licenses. We suspended only one license over a 7-year period of time. We canceled 2 licenses, and we only appointed an administrator 3 times. So in the absence of these more punitive, for want of a better term, suspension of license, cancellation of license, appointment of administrator, all of the other issues in these long-term care sites over this 7-year period of time were dealt with in a voluntary compliance sort of way. And the challenge is that we know that over a 7-year period of time, you're going to see some significant deficiencies and repetition of some of these deficiencies in some sites. So if we look at the American system, so the US, some of you may know already, long-term care is actually federally funded, and but it is regulated at the state level. But there's actually significantly robust data in the US system under the Medicare and Medicaid program of nursing homes, more so actually than Canada, because there is a national role in the US. There's not a national role in Canada. There's only provincial roles. So there's a national role over funding it, but a state role over regulating it. So I've just chosen one state to highlight this, California. So in the US system, they allow the leveling of penalties and fines for non-compliance. And again, you don't level a fine when you go in and do an inspection and you find you review the records of the staff and you find they're not up to date with some of the performance evaluations. You would write that up as a deficiency to be corrected. You would come back. The fines are really about egregious violations of the regulations or consistent and repetitive failure to meet maybe some of the lower standards. So you can see that based on the severity of the violation, direct proximate cause of death to a patient or resident, you can see how the fines vary there. And you can see from 25,000 to 100,000, much lower amounts for Class B citations. And what is interesting to look at over here is that there was $19 million. I'm going to get my, sorry about that. I'm trying to be able to see this slide here. You can see that clearly there was a state need for these types of fines. They were imposed. They do, when you look and review the literature, they do have a practical effect of bringing facilities into compliance more quickly than the voluntary process might otherwise do. The funds collected through the fine system, through the fines and penalties, are reinvested into the quality of the system. And I've long puzzled over our reluctance to do something similar like this in Canada. Ontario was poised to introduce a similar type of regime I think about 5 or 6 years ago, but it never moved forward. And when you think about all of our other regulatory regimes, our WorkSafe BC, certainly there are financial incentives for compliance and for best practices, and they do work. And the argument that the fines or the penalties would come out of care for the residents, I don't actually follow that logic. That's like saying that the fines issued by and the premium surcharges issued by WorkSafe BC come out of the resident care. They don't. And in fact, if we're having a more robust system of enforcement that is compelling sites to begin to comply more quickly, I think that is actually going to benefit the residents significantly. And prior to COVID, we saw some examples of that right here on Vancouver Island, where we had this extraordinary circumstance in the period of time of, I think it was over a 9 or 10 month period of time, 3 sites came under administration of the health authority. And the extraordinary extraordinariness of that is the fact that if you looked back in the preceding 10 years, over a 10-year period, there had only been a total of 3 ever brought under, and here we were in 3. And part of it was, when you looked back, there is an argument that you didn't need to get to that point if there had been a less voluntary type of regime for operators to come into compliance. It's, arguably the most level playing field you can have, and it's arguably the most transparent that you can have for all operators, whether they are not-for-profit, whether they're for-profit, or whether they're health authority owned and operated, frankly. So I think because when we talk about these national standards, which are a good thing, and they touch on a lot of the issues that I think we've come, the larger public has come to appreciate are necessary for quality in long-term care. They're only going to be as strong as their enforcement and as strong as the compliance of care homes to those standards, starting with the requirement for care homes to be accredited, because as we know, the standards are going to be applied through an accreditation process. So I think it really is time for us to think about, okay, if we are serious, and I think we are, I think the public at large is quite serious about its desire to improve life in long-term care for all residents, then I think we need to look at what are the measures we're going to put in place to ensure that quality of care is there. And when you have that question answered, the next question is, and what are going to be the consequences for those care homes who don't meet these quality standards? And that is where I think we need to have a little bit more of regulatory, not the oversight per se. We do have regulatory oversight, and we do have regulatory enforcement. What we need is consequences for non-compliance in meeting those regulatory requirements. And I think all the best plans that we put out there may work for 80% of the care homes, but that's of little comfort to those residents and their family members who are in the 20% of those care homes who are not complying with those regulations.